Silencing breast cancer. What is cancer? What is the definition? When the pathologist says this is cancer and this is benign, what are the parameters? Gone wild? What else? Speak up. Metastasis? What else? What makes it a cancer? This is cancer, this is not a cancer. Yes, right. It lives forever. If you give a cancer cell, a line of cancer cells, all the nutrients that they need, they will live forever. We don't get to do that. We're programmed to die. I can eat perfectly, breathe pure oxygen, whatever. I'm programmed to die. Cancer cells, if given the proper nutrition, will not die. That's a survival advantage. They invade. They will penetrate all barriers. A lung cancer will grow through the lung, into the ribs, into the heart, into the esophagus, into the trachea, right? And then metastasize. They're highly adaptable. Once you have a cancer, it's very hard to catch up. Cancer appears to be a progressive transformation. There are two ways of thinking about this. One is that you have a normal cell which goes through a series of genetic changes, becoming increasingly abnormal until it becomes malignant, then attains a, frankly, cancerous profile. It's able to invade, it's able to metastasize. There is another way of looking at it, which is to say that these pre-malignant cells are able to get into the circulation, and at a later date, they can become fully transformed. Very interesting, just published last week, a study out of, I believe it was MD Anderson, neoadjuvant chemotherapy given to women increases the number of breast cancer stem cells in their bone marrow. Who knows why? It's fascinating. You think you're trying to downstage and get at the cancer and see whether that patient is responding to the chemotherapeutic agents that you're giving, and you're actually increasing the burden of breast cancer stem cells in the bone marrow. So if we look at this sort of histologically under the microscope, we can see very clearly this is hyperplasia of the breast ductal epithelium. This is some atypia here. This is ductal carcinoma in situ. Here's ductal carcinoma in situ with invasion, and here's invasive breast cancer. The abnormalities continue to accumulate and get worse. We've got a low-grade breast cancer, an intermediate grade, and a high grade. In the old days, we tried to figure out how to treat breast cancer patients based on very gross parameters: the size of the tumor, the number of lymph nodes that were involved, and whether or not the patient had metastatic disease. So the type of surgery, whether or not the patient would get chemotherapy and what kind of chemotherapy, and whether the patient would get adjuvant radiation therapy, were based on this sort of system, the T&M system, and it really pertains to this day, although it is quite archaic. Additional parameters were then discovered: receptors, hormone receptors, estrogen and progesterone, and then they tried to refine things a bit by looking at nuclear grade and whether or not there was lymphovascular invasion. Lymphovascular invasion was actually high on the hit parade until about a week ago, when things change really day to day here. So the presence or absence of receptors, and to some extent grade of the tumor and the presence of lymphovascular invasion, would help determine some additional therapy that the patient might be given. Another receptor was identified, HER2, which is an epithelial growth factor. Patients who have these tumors have more aggressive breast cancer. Approximately 15 to 20% of patients will express HER2. And we now have targeted therapy with Herceptin to be able to treat these patients. And it works very well. I remember when I had first heard about Herceptin, this was probably about 8 years ago, maybe 9 years ago. And I had a woman who had a delay in diagnosis of her breast cancer, 6-month delay in diagnosis. She presented with about a 2.5 centimeter breast cancer lump in her breast. She was node negative by clinical examination. Her mammogram was completely normal. Her ultrasound was completely normal. Very baffling. She had a big lump in her breast. Took it out, looked at it under the microscope. It was just a garden variety invasive ductal carcinoma. It wasn't anything strange. It wasn't tubular. It wasn't medullary. It wasn't whatever. It was regular invasive breast cancer. So we did mastectomy. That's what she wanted, and axillary dissection. I forget how many, if any, lymph nodes. She did fine. She received, I think, chest wall irradiation. And then about 3 years later, she recurred. She had distant mets. And she was given one thing after another. She developed a malignant pleural effusion, lung mets, liver mets, bone mets. Herceptin had just come out. So we gave her Herceptin. She went into complete remission, complete. Unbelievable. Lived about another 3.5 years until she developed brain mets because it doesn't cross the blood-brain barrier. So I became a fan of Herceptin. It works very well. Breast cancers are now classified based on their receptor expression. You may have heard of this recently. So there's the luminal A and B. They're ER positive. The luminal A is the lowest grade, best behaving. The luminal B grows a little bit faster. HER2 is the next group. They tend to be high grade, worse prognosis, but they tend to respond to chemotherapy very well. And I can talk about that in a little bit. And then the basal, which is referred to as a triple negative, ER negative, PR negative, and HER2 negative. These tumors respond very well to chemotherapy, but they are known for early relapse and recurrence of disease. But now we enter a new frontier entirely. And the new frontier was sort of the point of departure for this, was the identification of BRCA1 and 2 in 1994. So here was a gene that was found in a population of women known to have a high risk for breast cancer. These BRCA1 and 2 genes are tumor suppressor genes, so when they're mutated, the suppressor is not acting properly, and the tumor, the cell is then susceptible to malignant transformation. In and of itself, it's not the only thing that causes a breast cancer. Women who carry a BRCA1 mutation have a 80% lifetime risk of getting breast cancer, but you don't know who they are. 20% never get breast cancer, but you don't know who they are, right? It's early onset disease. It tends to be bilateral disease. Tamoxifen will reduce the risk of contralateral disease by 75%, and prophylactic contralateral mastectomy will improve the survival by about 2 years. So BRCA1 and 2 identification sort of led the way to the exploration of the genes themselves. The term is expression array analysis, and I think this illustration is pretty clear. You look at the DNA, and you see what genes are being expressed, and you try and derive some prognostic information based on the array of gene expression. This led to the development of Oncotype DX, which is what we use in breast cancer. Researchers began with a pool of 250 genes. They matched them with large studies of women who had breast cancer to see which genes might correlate with various stages of disease and types of breast cancer. And they were able to narrow it down to 21 genes. These are the genes that relate to proliferation and estrogen and invasion and HER2 and so forth. And you use it by submitting the tissue for Oncotype testing, and you'll get back a recurrence score. So they'll do a gene array analysis based on these 21 genes, and they will tell you whether or not this tissue falls into a low, intermediate, or high risk for recurrence of disease. This is important because this is more specific. Remember, we started out with tumor size and lymph node status. That was very gross. And then we've got receptor status, which is a little bit more refined, but still pretty general. But now we're down to the level of the genes.